Now, Tiffany Malloy is and has over 20 years of healthcare experience, including outpatient behavioral health, AIDS behavioral health, provided within integrated care model, medical education, and home care. Right now, you're currently partnering with, and take it from there, what are you doing now that you're excited about this year?
What I'm really excited about is two things, actually. Private practice to meet the needs of people who are working and otherwise committed during the week. So there's a need for behavioral health care. I'm calling it Saturday psychiatry. So I'm going to offer that at the Straube Center in Pennington. The other big thing that I'm doing as a freelance consultant is working with medical home pharmacy.
That's a more complicated issue. What are you trying to do?
It is. So,
for the layman.
Okay, for the layman. So we talked about Obamacare before, and that's really a hot topic, and there are a lot of issues around that. One of the things that there's a need is about $300 billion a year is wasted on something called medication non-adherence. And what does that mean? It just means not taking the medication as prescribed. So if it's the right medication, it's an issue. If you have a cardiac problem and you're not taking your water pills and you end up back in the emergency room, now we have something called value-based care. And what that means is that the hospital is incentivized to keep you out for at least 30 days.
Is this good or bad?
It's good because previously, doctors and hospitals were paid, as many times as you needed service, you just kept getting paid, right?
Oh, and that's why.
But if they do a better job of discharge
up.
Planning, of transitional care, making sure you have your medication at home, you've got a doctor follow-up, then you're more likely to stay out of the hospital. So
the job that you do,
yeah.
Okay, what is it? People come to you and ask you for an opinion or what?
Right. So as a consultant, what I'm working with is hospitals, home care, pharmacy to provide, solutions to have better healthcare system delivery.
Hopefully more standardized so everyone understands it, which is so fragmented in this country.
So these aren't individuals coming to you, these are companies.
Right, and I'm approaching them as well because I'm sort of a disruptive leader, if you will, in terms of healthcare because we can't do the status quo anymore. And the way things have always worked, it just doesn't work. My focus is always what's right for the patient. And so I'm working with medical home pharmacy because they've invested in technology. These machines are extraordinarily expensive that make this strip packaging that really has proven to keep people out of the hospital. So what does that mean?
Yeah, basic example.
Right. So
I come to you, I need, give us example A.
Right. So you're a patient and you have been in the hospital 23 times this year because you are not taking your medication as you're supposed to.
Which my dad tells me happens. He's a doctor. It happens all the time. People don't even pick up the prescription.
Right. So one in five don't pick up the prescription, and 50% of us don't take the medication as prescribed. I mean, have you ever not finished an antibiotic course? For 7 days? Just taking it for 4 days, you feel better, you dump it.
If you don't finish it, they might have a relapse. You're in trouble.
But many people, 50% of the people don't finish it.
They do not. My dad said that's the biggest, it just drives you crazy. You could talk until the cows come home and they don't do it. You tell them how important it is. Right,
exactly. So pharmacies, post-Obamacare, they have identified that pharmacies and doctors should actually talk. They should actually talk. So they don't talk. Isn't that amazing? So I just gave a talk at Rutgers, actually, on improving the pharmacist and doctor relationship or provider relationship. So how do we do that? One of the problems is I used to do HIV psychiatry. So in HIV care, you need 95% adherence.
For it to work. So you have to be regimented and take those pills and have reminders the whole bit. Right.
So 95% of the time. So what happens in HIV care is there's a lot of addiction, there's mental health issues, there's homelessness, there's a bazillion reasons why people don't take their medication. So really we have kind of the same HIV numbers that we did 10 years ago.
All preventable. See, these are, even though it's complicated, these are all common sense steps to try to get everything.
But if the pharmacist and the provider don't speak, so what happens is if an HIV patient, I had one who got discharged and he changed insurances, right? Been on the same medication, stabilized for 10 years, same medication. However, the insurance company said, oh, we're not going to approve that medication. You have to have a pre-authorization. And in order to get the medication, we need lab work. So the pharmacy doesn't have the lab work at 6 o'clock on a Friday night, right?
Everything's
so then the patient drives 45 minutes home, never comes back. You really have to case manage and really assist that population. So that is a missed opportunity. So if the hospital or if the doctor were and it goes both ways, providing the information. And there's a lot of misunderstanding. You know, doctors and pharmacists, they're not really sure. Are we allowed to share information because of HIPAA? Are we not allowed? Do we need a signed consent? And the consensus that came out of a meeting I was at was that we can indeed share information because we're all practicing under the HIPAA Privacy Act.
Isn't that kind of funny? AMA, people think AMA is like a government agency. It's not. The doctors and they're your own entities too.
Right, the associations.
We hear a lot about big pharma, you know, promoting their advertising and getting people onto these various kinds of drugs they sell.
Psychotropic drugs.
Yeah, what's your views on that? You know,
Like, do you have a specific condition you're thinking
the
about?
whole big pharma issue with you know, because they have these massive marketing campaigns.
Well, Xanax
they can get people onto Medicaid. It makes them a lot of money.
Right.
That people are taking medications that they don't necessarily need or aren't necessarily the best for them.
He's talking about the dark side.
But there's kind of corruption.
Malfeasance.
Yeah, so, you know, I'm a clinician that my feeling is more balanced. There are many clinicians that I talk to that feel that, you know, pharma is more on the negative side. You know, it takes a lot of money. We actually pay for 80% of the world's R&D, research and development.
Yeah.
And some people
A lot
don't
of
know
that's
that.
government money, though, that goes to private corporations. Though,
It's very expensive to produce a pill.
It's very expensive to produce a pill. So, you know, I can't really comment on necessarily their intentions. But I think we have to look at the positive side. And when I have a patient that has schizophrenia, and I am able to get them on an injectable, and they stay out of the hospital, that costs us less money. They're doing better.
So
they have less complications. Psychiatric patients actually die 20 to 25 years earlier than the rest of us.
So you're kind of like you're like a lawyer, a psychiatrist. You know but you know the rules. You make connections, and you're a social worker to try to bring better care for people.
Yeah,
and
so
communication.
Right. So, for example, and it's sort of hard to explain, but it's critically important. If I work with a hospital unit, okay, and they're discharging patients, and they have, say, a 21% readmission rate or a 12% readmission rate, that costs the hospital money. Right. So, if I can work with a pharmacy, and Medical Home Pharmacies is a great example in Trenton. We have a program where they'll deliver the medication same day. Not at the bedside, not that whole bedside chain pharmacy program. Because when you're ready to go from the hospital, you're ready to go. You want to go home. You don't want to listen to a bunch of discharge instructions.
You don't want to get sick in the hospital either.
So, yeah.
It's a good place to die.
So the medication can go the same day. And it seems like a strange thing, but in the hospital, when you're there, it's a buzz. Everyone is really, really sick. The focus is on getting them really well and getting them out. And then on to the next guy. But what happens when they leave? Do they really take medication? Not a lot of patients don't have home care like they used to. And for psychiatry...
And families aren't together, you know, the family units aren't together.
Right. Yeah. So the strip packaging is proven, and then it eliminates pill boxes, but it gives people independent. So it's a pouch. So like all of your doses would be in one pouch. All your morning meds. You have 5 pills, they're all in one little pouch.
So
there's no pill box.
It's idiot-proof kind of in a way.
Yeah, I mean, it's great if you've got memory issues, and it's proven to
with
keep
the aging
people out of the hospital.
And the aging demographic population that we have.
Right. So if people take 80% or more of the medicine they're supposed to for chronic illness, they're about a quarter less likely to be hospitalized.
Are there a lot of people out there who don't have insurance, say, for these pills? You know, they're not covered, and thus they can't afford the pills that they would need?
Mm-hmm. Yeah, I think that's a great point. So if people qualify for Medicaid, they need to be on Medicaid. They need to go through the process and get on Medicaid.
That's a problem too.
People vet that.
Some people need help with that though too.
Yes,
the whole thing scares them. They're intimidated.
They absolutely. So people need help with that, but they need to go to the Medicaid office in Trenton, get vetted for that. If they don't qualify, the working poor is really the ones that I think that we have to worry about right now. There are a lot of small and medium-sized businesses that do not have insurance. They don't have health insurance for their employees. They have nothing. So those people, every single pharmaceutical company has a foundation where they will give the medication for free. But how do you get it? You have to get it through a provider like me or your previous guest. You have to have that written script, goes to the pharmaceutical company that you were just saying might be very negative. So this is a positive for them. And the threshold sometimes is up to $80,000 a year. So if you make too much for Medicaid and not enough, but you're not over that threshold, you can get free medication for a year. Brand name only. They don't do, this isn't for generic.
In the remaining time, so I did an interview about what you do. So you look at office visits, hospital admission, filling prescriptions, target population, preventative, diagnostic. What about you? Quickly, I'll throw 5 questions at you to see what you can answer. What motivates you in this job? Your greatest accomplishment? What's your best problem-solving skill, and what have you learned from your patients? Pick any one of them, I can repeat them.
Okay, so the private practice that I'm doing, HIV psychiatry taught me a lot about adherence and figuring out what makes people tick. I love addiction care, so I treated a lot of crack cocaine, a lot of smoking, and smoking cessation is a fascination for
nicotine.
me. Yeah, so nicotine, so I'm also a tobacco treatment specialist. I went through a 40-hour course at UMD&J, and Dr. Jill Williams is absolutely brilliant there, and she really hammers home that actually smoking is the, #1 killer.
Yeah,
it's not necessarily heart disease and the rest. It's a trickle down. So, but it can be successfully treated, but you really have to start with the love affair with addiction. You've got to start with the love affair of the cigarette.
Do people with certain kinds of tendencies to maybe to overeat or to drink, I think they're the people who want to medicate with nicotine too.
That may be, an addictive personality where, you've got several different things going on. But right now, you may say to yourself, well, not that many people smoke. It's not a big deal. But it is a big deal for the people who do smoke. They can't smoke at work. It's a shameful thing. They really can't get rid of the habit. It's not something they want to talk about. But it's highly treatable if you treat the anxiety, the sleeplessness that goes along with it, get them the medication that they need if they don't qualify, write to the company and get to it. But you've got to do a multitude of things. Cigarettes, each cigarette's 2 milligrams of nicotine, right? So if you smoke a pack a day, how many milligrams is that?
20.
It's a delivery
times
system
2, right? So it's 40 milligrams.
40.
So if you have 40 milligrams of nicotine going in your system every day, is a 21 milligram patch going to cut it for you?
No, it's serious addiction.
Absolutely not. But we have to start with the love affair, what they love about the cigarette, taking the wrapper off, doing their packing, their routine, what brand they smoke, what it looks like. All of that is
breaking
discussion.
the psychology of it.
Yeah, it's not about when you're going to quit and quitting. It's about the love affair.
Right.
And that really, because most people will say, well, you have to quit, it's bad for you. When you ask a patient, like, what do you really love about smoking?
Some people
their
tell me
face lights up.
it gives
They
them
get so
something to look
excited.
forward to. Some people even said that to me. It's something to look forward to. It's something to do.
Absolutely. Well, it gives you a dopamine release. So you get the same release that you get with sex, with chocolate, with other things. And actually, the nicotine goes to the brain faster than IV heroin.
What have you learned from your patients, though? With all your work, and I guess you say from patients, doctors, what have you come off? If you could distill some words of wisdom.
Yeah, so what I've learned from my patients is that we can't control others, we can only control ourselves, right? And
hopefully.
it's really with the human connection. It's really like connecting with that person. Once you connect with them and you get them, they think you get them, that's when I think some change starts to occur.
They open up a little bit and everything.
Yeah, yeah.
What do you see, if you can give us the next 5 years, generally, what do you see the future going with Obamacare and this type of care that you're trying to provide, the holistic, standardized care with people? What's going to happen, especially with the aging population?
I think this is a great opportunity for entrepreneurs, actually, to get into the game of improving healthcare system delivery and connecting either their product or somebody else's product on reducing hospitalizations, keeping people healthier, reducing our costs. See, the goals with Obamacare is better health, access to care, and reduce cost. So we have to focus on those things. But I think it's a great opportunity for entrepreneurs to get into the game.
What you're doing and everything else.
Yeah, there's technology, there's texting to decrease no-show rates. How do we connect with people, get them back in the office so that they get the care that they need? When patients don't show up, they don't get medication, right? So how do you handle that? There are many, many companies that are trying to get into the game on that.
Well, thank you, Tiffany Malloy at TiffanyMalloy.com. And it's going to hopefully come back and see what's happening. And God, you have a lot of answers. I have more questions.
I have a lot of energy.
Yeah, thank you.
Thank you.